Hello, everyone, and welcome. If you're an MBBS student, you know how some topics are just so important for your exams. Well, today we are going to dive deep into one of those, the anal canal. We're going to break it all down into simple, high-yield points that you can actually remember. Okay, so here's how we're going to tackle this. First, a quick overview. Then we'll get into the layers and the all-important sphincters. After that, we'll see how continence actually works. Then we'll move to the clinical side of things, the examination. And finally, we'll touch on some key conditions you are bound to see. Simple, right? Let's jump in.
Right then, first things first, let's get the basic blueprint of the anal canal sorted out. So take a look at this diagram. What we're seeing here is the anal canal, and it's actually quite short, only about 3 to 4 centimeters long in an adult. You can see it starts right where the rectum begins to narrow down. That's as it passes through the pelvic diaphragm, and it finishes right at the anal verge, which is, the opening to the outside. Okay, now this is super important, especially for your practicals. The anorectal ring. You can actually feel this during a digital rectal examination. It's this muscular ring that tells you exactly where the rectum ends and the anal canal begins. Trust me, learning to palpate this is a fundamental skill you've got to master. Okay, so we've got the basic layout. Now, let's go a bit deeper and look at the actual structure, the layers and the muscles, especially the sphincters, that make it all work. All right, listen up, because this next point is a classic Viva question, the dentate line. Now, it might just look like a line on a diagram, but it is so much more than that. Think of it as an embryological border. Everything above it comes from the endoderm, and everything below it comes from the ectoderm. So what, right? Well, this is huge clinically. It means they have completely different nerve supplies, blood supplies, the whole lot. A perfect example, hemorrhoids. The internal ones above the line don't hurt, but the external ones below the line, they can be incredibly painful. And that difference, it's all because of this one little line. This table right here, you need to know this. I mean, really know it. It's a guaranteed exam question. The two sphincters are totally different. The internal one is smooth muscle. It's involuntary, you can't control it, and it looks kind of pearly white. The external one, on the other hand, is striated muscle. It's under your voluntary control, and it's red. Just memorize this table. It will save you a lot of trouble. And here we have the puborectalis sling. Just look at how it wraps around that junction. The analogy of a kink in a garden hose is perfect. That's exactly what it does. It pulls the canal forward, creating this sharp angle, the anorectal angle. It's a really clever, simple mechanical trick that is absolutely crucial for maintaining continence. Okay, so we've got the parts list, right? We know the anatomy. Now let's see how all these pieces fit together to do their main job, maintaining continence. It's a pretty elegant system, actually. So how does your body know what's, waiting? It's all about this clever little thing called the recto-anal inhibitory reflex. When the rectum starts to fill up and stretch, it automatically triggers the internal sphincter to relax just a tiny bit. This allows a small sample of the contents, whether it's solid, liquid, or gas, to come down and touch the super sensitive lining of the upper canal. Your brain gets that sensory information and goes, okay, what is this? And then you can make a conscious decision, either squeeze the external sphincter to hold on, or, find a restroom. Right, so that's the theory. Now for the really important part, for all you future doctors, how does this apply at the bedside? Let's talk about the clinical examination. When you're doing an examination, it's a simple 3-step process. Don't skip any. First, you just look. Inspection. Gently part the buttocks, have a good look at the skin around the area. Then, step 2 is palpation. With a lubricated, gloved finger, you assess the sphincter tone. You can even ask the patient to squeeze so you can check the voluntary muscle function. You're also feeling for any lumps or bumps. And finally, if needed, you would use a proctoscope to get a direct look inside. Inspection, palpation, proctoscopy. Easy to remember. And of course, you can't do a good exam if the patient isn't positioned correctly. It's crucial for their comfort and for you to actually see what you are doing. The most common position you'll use is the left lateral, or Sims position. But sometimes, especially for a better view, the knee-elbow position might be necessary. Okay, let's wrap up by looking at what happens when things go wrong. We will focus on one of the most common conditions you will definitely see in your practice, hemorrhoids. Now, not all hemorrhoids are the same, and you have to be able to classify them because the treatment is completely different for each. It's a simple grading system, from 1 to 4. First degree, they just bleed, you don't see them. Second degree, they pop out when the patient strains, but they go back in by themselves. Third degree, they pop out, but the patient has to physically push them back in. And fourth degree, they're out and they're staying out. They cannot be reduced. See? This classification is your guide to what to do next. So what do we do for, say, a second-degree hemorrhoid? Well, one very common procedure is this: rubber band ligation, or Barron's banding. It's quite simple, really. You place a tiny, tight rubber band right at the base of the hemorrhoid. What does that do? It cuts off the blood supply. And without blood, the tissue dies and just falls off in about a week. It's a very effective outpatient procedure. And I want to leave you with this classic saying. You will hear it a lot in surgery wards. If you don't put your finger in, you might put your foot in it. It is a bit blunt, but the message is absolutely critical. For any patient with anorectal symptoms, a thorough clinical exam, including a digital rectal exam, is not optional, it is essential. Don't ever forget that.